Chapter 23, Behavioral and Psychiatric Emergencies, including suicide. So, patients may present with an unexpected or dangerous behavior, and it may result from a lot of different things. Not always is it psychiatric. Stress, physical trauma or illness, drug or alcohol abuse, and of course, a psychiatric condition. So what really is a behavioral emergency? Behavior is a manner in which a person acts or performs. When it becomes an emergency, their behavior is not within a given situation, or it's unacceptable or intolerable either to the patient themselves, to family, or to the surrounding community. You also can look on page 619 so you can follow along on the chapters. So, what is a behavioral emergency? Behavioral patients may appear confused and also have altered mental status. Not always is it a psychiatric condition, though. There's any number of things that can cause a behavioral emergency. Look on page 621. Low blood sugar. We already know that that can present as erratic or hostile behavior. Lack of oxygen changes mental status. Stroke or inadequate blood to the brain. Head trauma and mind-altering substances. But true psychiatric conditions might involve anxiety or a panic disorder, which lots of people have, depression, bipolar disorder, or schizophrenia. And if you're looking on page 621, there's approximately 1 in 4 people that actually suffer from a diagnosable mental disorder. Almost 7% of the population has a mood disorder, including depression. Slightly more than 18% have anxiety or panic issues. But the other conditions, schizophrenia, 1.1%, and bipolar, 2.6%. But there is a lot of mental conditions, psychiatric conditions out there. Physical causes of altered mental status might include low blood sugar, lack of oxygen, stroke or inadequate blood to the brain, head trauma, mind-altering substances, and environmental temperature extremes. Situational stress reactions. Normal reactions to stressful situations produce emotions. Fear, grief, anger, and some of this might be normal depending on what is actually going on at that particular time. So if you're caring for a patient with a situational stress reaction, don't rush. Tell your patient that you're there to help. Try to remain calm. Keep your emotions under control. You're there to listen to the patient. Be honest. Stay alert for changes in behavior. Remember, you chose to be there for that person. They didn't necessarily choose you to come. So they've called 911 for help. You have chosen to become an EMT and to be that person to help. So let's be empathetic with their situation and see if we can't help improve the problem that they are presented with. Acute psychosis. This involves a severe break in the patient's ability to process information and interact with their environments. It's often associated with a cognitive disorder such as schizophrenia. So, acute psychosis has occurred when the patient develops one or more of the following symptoms: hallucinations, delusions, catatonia, or a thought disorder. So, looking for those specific things for acute psychosis. Are they seeing things that aren't there? Or are they delusional? Do they have ideas of grandeur that might not be consistent? Catatonia, they don't respond to their environment, or they have some type of thought disorders. This will impact the patient's ability to process information and to communicate, and also can cause unusual speech patterns or strange writing. Utmost importance, make sure it's safe for you and for the patient too. Okay, assessment and care of behavioral and psychiatric emergencies. There's a range of presentations. You really don't know what's going to happen, and um, you have to be able to be prepared for anything. They might be withdrawn and not communicating, or they might be completely talkative and agitated and hard to calm down. They might have bizarre or threatening behavior, might wish to harm themselves or others. If you can try to keep that situation under control so that they and limit their accessibility to any type of tool or device that can harm you or themselves or others. Key techniques: identify yourself in your role, speak slowly and clearly, make eye contact. You need to show to them that you are there to help and can be trusted. So listen to the patient. Do not be judgmental. Use positive body language. Standing there with your fist closed is not positive language. Crossing your arms is not positive language. So you need to present an open, prepared, still, but body language. Acknowledge the patient's feelings. Do not enter the patient's personal space. Stay at least 3 feet from the patient. Be alert for changes in emotional status, and use restraint to prevent harm only if necessary. There's a lot of rules when you're going to have to restrain somebody, and so you want to thoroughly be aware of how and when and why you would do that. You can reference that on page 628. The other reference I want you to look at in your chapter is about neurotransmitters. This is a little bit about pathophysiology of how our nervous system works, and why the patient might be on some different types of medications. There's a medication that's called a selective serotonin reuptake inhibitor that works on the nerves. And read that thoroughly so you know which types of medications might actually be working for that patient. If you look at their medications, you would know that it's a neurotransmitter. So here's some general rules for interactions. If you're going to restrain somebody, if you find that it's necessary, you need to plan your approach to the patient in advance and remain outside the range of the patient's arm and legs until you're ready to act. So you're going to have 4, at least 4, 5 if available, and each person is going to take a limb. Everybody's going to know ahead of time which limb they're going to take. So the 5th rescuer is going to control the patient's head, but watch out for not being bitten. So perform a careful scene size up, identify yourself and your role, complete a primary assessment, perform as much of a detailed exam as possible, and gather a thorough history. Some common signs and symptoms that you might see: panic or anxiety, an unusual appearance, disordered clothing or poor hygiene, agitated or unusual behavior or activity, unusual speech patterns, bizarre behavior or thought patterns, suicidal or self-destructive behavior, or violence or aggressive behavior. Be alert for personal or scene safety problems and treat any life-threatening problems that might arise. Consider medical or traumatic cases. Spend some time talking with the patient. Encourage them to discuss their feelings, but never play along with hallucinations. Don't play into them. And consider involving family and friends. Sometimes that can help. Suicide is the 8th leading cause of death. It's the 3rd leading cause in the age group ranging from 15 to 24 years old. So there's a lot of people that commit suicide. Rising numbers in older adult population too. Depression seems to be taking over in a lot of areas. So a potential or attempted suicide. You need to explore the following possibilities. Are they depressed? Have they had high stress levels? Recent emotional trauma? What is the age group? 15 to 25 and 40 plus are the highest risk. And is there drugs or alcohol abuse involved? Potential or attempted suicide. You want to take into consider anybody that threatens suicide might potentially be serious. Do they have a plan? If they have a plan, they're more likely to implement it. Are there previous attempts or threats? And is there a sudden improvement from depression? Sometimes they start preparing for the event by maybe giving things, personal items that are important to them, away. Your personal interaction is important. Don't argue, threaten, or indicate using force. Remember your scene safety. Remember the primary assessment. Treat those life-threatening problems. Perform a secondary assessment and a detailed exam, and reassess frequently, and notify the receiving facility. So a patient is a 23-year-old male. His girlfriend called 911 after a domestic dispute. He is uncooperative and refusing treatment. The girlfriend reports the patient is depressed and suicidal. He owns a gun and has threatened to shoot himself. What do you do with this? Well, this is a situation that can't be ignored. The patient refuses treatment. You can't take him against his will. Only a police officer can restrain somebody, so you need to get the police involved. If they are a threat to themselves or others, they can be taken in under a 72-hour hold order. So, can you treat the patient if he did not call? No, you can't. He can refuse. Should you believe the girlfriend? Yes, you should. Does the patient need treatment or transport? Yes, he does, if he threatened suicide. Can you treat and transport the patient against his will? No, but you can involve the police officers. So consider some clues. Look at the dispatch information. Look for information from family or bystanders. Take into account the patient's stance or position in the room. Are you in a safe place? Is he showing aggressive behavior? Make sure you have an escape route. Don't get yourself blocked into a place where he could attack and you can't get away. Do not threaten the patient. Stay alert for weapons of any type. Ensure your safety. Calm the patient if possible, and then try to get a thorough assessment and restrain the patient only if absolutely necessary, and use that procedure and that plan. And once again, make sure that you have sufficient personnel to do the job. You have to ensure your safety as well as the patient's safety. And restraining people is a high liability in EMS and in law enforcement. You want to follow the guidelines on page 629. And when you're going to restrain somebody, be sure to have adequate help, plan your activities, estimate the range of motion of the patient's arms and legs, Until you're ready, stay behind there. Once the decision to restrain the patient has been reached, act quickly. Have an EMT talk and reassure the patient through the restraining procedure. Approach with a minimum of 4 people, 1 person for each limb, and then secure all 4 limbs. And then position the patient face up, never prone or face down. We don't hog tie people, because then they're at risk for something called positional asphyxia. So, patient care, do your scene size up, request additional help if necessary, seek advice from medical control if necessary, watch for sudden changes in behavior, reassess frequently, and consider restraints. Here's your reasonable force necessary to keep the patient from injuring themselves or other. Reasonable is determined on the patient's size and strength, the type of behavior, their mental status, and available methods of restraint. Some systems do not allow restraint without police, or medical control orders, so never attempt restraint without proper legal authority and sufficient assistance. There's a condition called excited delirium. It's where the patient is extremely agitated or psychotic, has psychotic behavior during struggle, and it's followed by a cessation of struggling, and then they have respiratory arrest, and then death. So you really need to watch out for excited delirium. The patient is often hyperthermic and shouting incoherently, so they're hot, they're agitated. Usually they have been on cocaine, so they're like really excited, and their adrenaline is stimulated, and they are at risk for sudden respiratory arrest and then death. So especially if you hogtie these people, that would be a real high risk. You could be liable and probably accused of murder. So, excited delirium is often linked to improper restraint in a position where patient cannot expand his chest to breathe adequately. It's called positional asphyxia. And be alert for this sequence of events. Anytime you're going to restrain somebody, make sure you can monitor their airway. So, when you restrain a patient, have adequate help, plan your actions, stay beyond the patient's reach until you're prepared to take them down, and when you're ready to do it, act quickly. What happens? Well, one EMT talks to and calms the patient, and all 4 people, 1 on each limb, will come together and restrain all limbs with approved leather restraints in the supine position. Always face up. You are responsible for any restrained patient's airway, so ensure that you can adequately secure it throughout transport. You can apply a surgical mask if they're spitting on you, or a non-rebreather if they're restrained. Reassess frequently and document thoroughly. Not all hospitals are prepared to treat behavioral emergencies, so the police really need to go along with you so that they can ensure adequate transfer of care. Choose a correct facility based on capabilities and local protocol. Remember, refusals and restraints cause significant medical legal risk because you are doing this without somebody's consent. Laws typically allow providers to treat and transport patients against their will if they are a danger to themselves or others. And local protocol may require medical control contact or police presence. You're safe to have police there. Sexual misconduct. Behavioral patients, especially those requiring physical contact such as restraint, sometimes accuse EMS providers of sexual acts. So you might want to have the same-sex provider attend to the patient and have a third-party witness present at all times on scene and during transport.
Occasionally, patients will need to be physically restrained during ambulance transport. These patients are usually severely agitated, combative, and violent for a multitude of reasons. Keep in mind that medical emergencies such as hypoglycemia, hypoxia, head injury, and intoxication can cause a patient to become unruly too. Never assume that the patient is simply acting out or trying to be difficult. While you may need to restrain the patient, a thorough assessment and treatment for any medical cause of combative behavior should be happening simultaneously. When the determination has been made that the patient is a danger to himself or others, reasonable force and restraint can be used. Reasonable force is the minimum amount of force used to control the patient. The goal is to restrain the patient, not to hurt them. Physical restraint is always the last option and should never be used as a punishment for a rude or uncooperative patient. Never attempt to restrain a patient alone. Positional asphyxia has been reported in the literature when patients have been hog-tied or restrained in a manner that impairs breathing. Patients should be restrained in a face-up or lateral position, never face down. In many areas, law enforcement or medical control must authorize restraint and treatment of patients against their will. Quickly perform a scene assessment. Make sure that the scene is safe and that the patient is not carrying a weapon. Have law enforcement ready to assist if the patient is carrying a weapon. Try to have an exit strategy and stay at least an arm's distance from the patient until actually ready to begin the restraint process. When the application of soft restraints is determined to be necessary for the protection of the patient, crew, or bystanders, take the following steps. BSI precautions. Plan your actions ahead of time. At least 4 people are required to restrain a patient. Each person should be pre-assigned a limb to restrain. Rescuers should all act at once to overwhelm the patient. Attempt to grab clothing or large joints. Avoid placing pressure on the neck, chest, or face to avoid interfering with breathing and/or getting bit by the patient. Secure all 4 limbs with approved restraints. The patient should be secured on the ambulance gurney or backboard in a supine or lateral position, usually with one arm up and one arm down. Placing a sheet or blanket over the lower half of the body can help prevent the patient from kicking. It is a good idea to have oxygen on the patient due to the medical causes of combative behavior. The mask will also prevent the patient from spitting on rescuers. Continually monitor distal circulation in restrained extremities to ensure the restraints have not been applied too tightly. If a restraint needs to be loosened, get help and loosen only one limb at a time. Once restrained, do not leave the patient at any time. Consider having extra personnel in the ambulance's patient compartment during transport in case the patient escapes restraint. Do not remove restraints unless sufficient personnel are available to control the patient, usually at the hospital. Do not allow the patient to talk you into removing restraints by promising to behave. ABCs should always be monitored in the restrained patient. Patients that appear to calm down may actually be deteriorating, so be vigilant. Attempt vital signs every 5 minutes in patients whose conditions are changing or are critical, and every 15 minutes in stable patients. Document why and how the patient was restrained. If the patient continues to struggle violently, requiring multiple people for restraint, consider ALS resources for chemical restraint.
As an EMT, you may respond to many behavioral emergencies. Be sure to ensure your own safety before entering a scene or caring for a violent or potentially violent patient. A considerable portion of the population has a diagnosable psychiatric condition. However, not all patients are violent. It is important to remember that patients in crisis are patients and people who need your compassion as well as your care. Always consider patients acting in an unusual or bizarre fashion to be experiencing an altered mental status. This will help you to avoid overlooking a medical or traumatic cause for the patient's problem. Because treatment of these patients usually requires long-term management, little medical intervention can be done in the acute situation. However, the way you interact with the patient during the emergency and assess your patient throughout the call is crucial for their continued well-being. Safety is the first priority when approaching a patient with altered mental status. Psychiatric and behavioral emergencies are prevalent in our society. EMTs should treat them as they would any other potentially life-threatening disorder. Assessment of altered mental status should rule out physical causes first. Psychiatric and behavioral emergencies can present differently depending upon the disorder. There are best practices EMTs employ in approaching, assessing, and treating such patients. Follow local protocols and use appropriate procedures to restrain patients when necessary. So, what methods help calm the patient suffering a behavioral or psychiatric emergency? If you're calm, the patient will be calm. What can you do when scene size up reveals it is too dangerous to approach the patient? Never approach until the scene is safe. What factors help assess the patient's risk for suicide? As we saw, their age, situations in their life, and sometimes medications that they might be on. So you respond to an intoxicated minor who is physically aggressive, threatens suicide, and whose parents permit you to treat, but not transport the patient. How would you manage this patient? Could you convince the patient's parents to let you transport? Is this beyond your scope to treat somebody that is threatening suicide?